Good morning, everyone present here. I'm Dr. Rajesh Kunanki. Today, I'll be presenting a paper on topic IOP monitoring preoperatively and postoperatively, or observations at Dr. Perikushi Reddy Government Regional Eye Hospital, Colonel Medical College, Kurnool. Inflammation is a natural response to tissue damage due to cataract surgery, which can be damaging to the ocular environment. Steroids, via any route, inhibit production of leukotrienes and prostaglandins, thus decreasing the inflammation and hastening the recovery process and better visual outcomes. Steroids have significant side effects, and the most common complication being increase in intraocular pressure. Other risk factors that increase intraocular pressure include pre-existing glaucoma, advanced age, diabetes, high myopia, pseudoexfoliation, vitreous, residual cortex, or viscoelastics in the anterior chamber. Persistent elevation in intraocular pressure can lead to optic nerve damage and visual loss. Coming to the inclusion criteria, age 50 to 80 years were taken in consideration. Sex, both males and females were taken. Patients who underwent uneventful small incision cataract surgery or phacoemulsification. Exclusion criteria, patient who had previous history of glaucoma, patient with complicated cataracts and previous history of iridocyclitis, patient with complications during cataract surgery, patients already on corticosteroids, either topical or systemic, patients who have connective tissue disorders. Aim of the study is to evaluate IB fluctuations following cataract surgery with topical corticosteroids. This is the observational cross-section study of 200 patients conducted over a period of 3 months among patients attending the cataract OPD at REH Kurnool. All the patients were recorded by non-contact tonometer preoperatively compared with first day, first week, second week, fourth week, and 6th week postoperatively. Patients were given fixed topical eye drops with fixed drug combination of 0.3% chylofloxacin and 0.1% dexamethasone sodium phosphate for 6 weeks, and it was tapered weekly. High-risk patients were given NSAIDs eye drops after second week and lubricant eye drops in suspected dry eyes. The following parameters were assessed: fluctuation in intraocular pressure from baseline, difference in recorded IOP at different time period, age and sex, steroid response, which was graded according to the rise in IOP from baseline conducted by Armali et al. Study. Low fluctuation in IOP was rise in IOP less than 6 millimeters of mercury. Medium fluctuation was rise in IOP by between 6 to 15 millimeters of mercury. High fluctuation greater than 15 millimeters of mercury. Coming to the results, in our study, we observed steroid-induced IOP elevation following topical steroids after 4 weeks post-op. The prevalence of steroid responders in our study was 9%, which was 18 patients. Mild rise was noted in 5.5%, which was 11 patients, and moderate rise was noted in 3.5%, which is 7 patients. None of the patients in our study had severe rise in IOP following topical steroid eye drops for 6 weeks. The highest mean IOP was noted at 4th week, being 23.5 millimeters of mercury, and second highest mean IOP was noted, which was 21.23 millimeters of mercury at first week follow-up, which was mostly due to post-op inflammatory reaction. Coming to the study, we have a higher number of males compared to females. Patients between 56 to 60 years are higher in our study. Now coming to the results, we have seen there is decrease in intraocular pressure by 1.03 millimeters of mercury on the first day, and there is subsequent rise at first week by 5.98 millimeters of mercury, and at fourth week by 8.27 millimeters of mercury from the baseline. This graph shows there is a peak at the first week and at the fourth week of the post-op follow-up. Coming to the discussion, the study done by Amali et al. Demonstrated that older adult population had higher risk of steroid-induced increase in IOP compared to the younger patients. But according to study conducted by Kusni et al., it demonstrated that there is statistically significant difference between there's no any statistical significant difference between the age group and the genders as compared to the IOP rise after surgery. According to the study conducted by Hongyu Dong et al., it demonstrated that topical steroid NSAIDs are equally efficacious when compared to topical steroids, and ophthalmologists should consider using 2-drug regimen in managing post-op cataract extraction. There's a paradigm shift in pharmacotherapy uncomplicated cataract surgery has deviated little from the norm, as indicated by the American Academy of Ophthalmology. Based on this current study and others, the authors believe that the pharmacological approach should be tailored to each patient. In our study, we observed there was a statistical significant difference, p-value being 0.03, in mean IOP between preoperative and with postoperative follow-up. The mean IOP on 4th week following cataracts was higher than the preoperative, which gradually decreased till 6th week follow-up. Coming to the shortcomings of our study, the sample size is small. IOP was measured with non-contact tonometer only. Comparison was not done between the patients undergoing SICS and the phacoemulsification. Surgeries were done by senior faculty and postgraduates. All the patients were put on fixed drug combination supplied at hospital and not compared with other steroid regimens. Coming to the conclusion, steroid-induced intraocular pressure elevation was observed mostly after 4 weeks of topical steroid therapy. The prevalence of steroid responders is relatively significant in our study sample, being 9%, thus coming to conclusion that topical steroids should be used judiciously. Topical steroids should be tapered early and can be replaced or supplemented with topical NSAIDs and lubricant eye drops. In most cases, the IOP lowers spontaneously to the baseline within 2 weeks upon stopping the steroids. This small study highlights the need of IUP evaluation at every post-op follow-up and the need for alternative, safe post-op treatment regimens. Thank you.
Thank you. Thank you, everyone. This concludes the session. Sorry that it took more time. In patients where NCT was more than 20, did you try doing applanation tonometry, or you just went with the NCT? That's why you have given it as a shortcoming. Okay.
Where the IOP was high, did you put them on any anti-glaucoma medication?
No, sir. We did. We stopped that drug and we did. Is there any subsequent decrease in the IOP in the following weeks? So that there was no subsequent decrease in the IOP. Then
Yeah. Can you not correlate the increased IOP because of the post-operative inflammation rather than the steroid use? How do you differentiate both? IOP can also occur after cataracts because of increased inflammation. That is an important cause also to consider. Yeah. Should document in the slit lamp examination, like a flare of the cells.
Is there any cell flares greater than 2+?
That will be there in all cases. Within a day, all cases will be there. So how do you differentiate IOP because of increased inflammation, IOP because of steroid use? It's important to differentiate. Thank you so much.